Okay. Hello again, BRAINterns. Thank you all for joining us for our second webinar of the day. We are so excited to have you guys back. Yesterday, we were really happy to see how many people were engaged and interested in our spine neuroanatomy webinar with Akesh Mishra. So thank you all for joining us again. We're going to have our next speaker, Dr. Jonathan Rasouli. He is the Director of Complex Spine and Spinal Deformity Surgery at Staten Island University Hospital, which is an affiliate of Northwell Health. And he's going to be going through a spine virtual OR with us and talk about different surgical techniques that can be used to address spinal deformities. Before we begin, I just want to share that, yes, this recording will be posted on YouTube by tomorrow. So if you have to log off early and you want to hear the rest of Dr. Rasouli's talk, it will be on YouTube. The recordings will be posted on YouTube for each session. Also, please send your questions using the Q&A function. I'm going to enable the chat. As a reminder, there is no crosstalk in the chat. We want to keep the chat professional, and if there's any inappropriate language or unprofessional language, we will disable the chat for the rest of the webinar series. So don't ruin it for your colleagues, your fellow BRAINterns. Keep it profesh, okay? Without further ado, I'm going to pass off the spotlight to Dr. Jonathan Rasouli. Thank you so much for joining us today.
Thanks so much, Hannah. I greatly appreciate it. Thank you very much for the wonderful introduction. I just wanted to thank all of you for having me here on BRAINterns. It's great to talk to the upcoming, hopefully the upcoming and future neurosurgeons that I'm going to be working with when I'm old and gray and a seasoned attending. So just a little bit about me. I am a neurosurgeon. I primarily do spinal surgery here at Northwell. I work at Lenox Hill Hospital and Staten Island University Hospital in New York City. I'm predominantly at Staten Island University Hospital though. My interest is mostly complex spine, scoliosis, spinal deformity, and a whole host of different spinal issues. Basically anything related to the spine, I'm interested in. So I want to keep this kind of easygoing, kind of conversational. If you guys have any questions whatsoever, just put them in the Q&A. I'm happy to kind of stop and answer things. I'll do some periodic stops throughout the talk as well too, to see if you have any questions. So please feel free. But I just wanted to start a little bit about me. I'm originally from New York City, North Jersey. I've kind of been in this area my entire life. I did my medical school at Albert Einstein, and I did my residency at Mount Sinai in the Upper East Side. And then I did my spinal surgery fellowship at the Cleveland Clinic in Ohio. So I've kind of been a little bit all over the place, but mostly in New York City. I joined Northwell in October of 2021, and I've been here ever since. It's been great. And let me just talk a little bit about what I do, what to expect in a kind of a complex spine OR, and yeah, let's get to it. If you have any questions, just let me know. Okay. So I'm going to start a little bit first, just a little bit of general stuff. So neurosurgery, right? When you think of it, when I thought about it when I was in college, I never even thought about neurosurgery when I was in college. For the longest time, I wanted to be a cardiologist. And it wasn't until I had some great experiences in my medical school, and in particular in my third year, where you rotate through different specialties, that I got interested in neurosurgery. So I always thought to myself, wow, a brain surgeon. Oh my God, that's so cool. Like operate on the brain and the spine. It's so intriguing. Like who even sees that? It's so complicated and so weird. And it was all really, really cool. The things I really liked about neurosurgery were a couple of things. I kind of thought about this and I summarized them all in one slide. The patients are very challenging and complex. No day is the same. Everyone's different in some way. You always have to think. You always have to think on your toes and use your training and your knowledge, your experience to come up with a plan for the patient. It's something that will ultimately help this patient. It's very dependent on. It's not only just kind of the medicine that we do, but it's also technology. The field advances and gets better with technology. It does not get replaced with advancements in technology. We just get better as the technology improves, which is what I really liked about that. Everything we do is state of the art, complicated surgeries, very, very minimal room for error in many ways. And one of the tenets of surgery in general is just you have to enjoy working with your hands, right? You have to be there in the OR, calling the shots, make sure things are going smoothly. These are all things that kind of go with that personality of someone who ends up going into surgery or neurosurgery in general. And then, of course, last but not least, but probably actually, no, it is actually the most important is helping people. At the end of the day, you're always helping people. You have that gratitude and that job satisfaction. I think it's unparalleled and unmatched in any other field, that you're really truly able to use your skill and your knowledge set to help people in a way that's very, very few people can actually do. So if you broadly think about it, neurosurgery can be broken up into different subspecialties. You have tumor, vascular, so on and so forth. The one I got interested in was in spine. And what I liked about spine in particular was that, in one surgery, you can go from doing some of the, most intricate microsurgical, using a microscope, operating directly on the spinal cord, to, the most macroscopic, where you're using chisels and hammers and drills and putting screws in the spine. So it was like you had kind of the whole spectrum and range that could all be in one surgery. So I thought it was very cool. And I really liked the spine patients. I liked the pathologies that they had. I liked the surgeries. I thought they were very, very cool. And I liked the people in spine. I felt like I really clicked with them. So what are the traits that we're looking for in a neurosurgeon and, let's say, a neurosurgery resident applicant that's more, I guess, more prevalent or more relevant to you guys? So, we're always looking for people who are altruistic, right? They treat the patient like their family member. We're always looking for people who have strong attention to detail, they're hardworking, so on and so forth. You can read the slide. Now, it's not all good, right? There are obviously some downsides. I'd say these are the ones that I thought of as being I thought these were the biggest downsides. They may not be downsides to you. Maybe these are upsides, but I always thought these were pretty bad. It's the longest residency program. The hours are pretty terrible at times. The patients can be quite challenging, quite complicated. You're always understaffed. You always feel like you're the lone wolf in many ways, and it can be stressful. Definitely be stressful. So this was a little comic that came out when I was in medical school. It seems very outdated now, but it's still relevant in many ways. So if you look at the top right, the neurosurgeon, right? Workaholic egomaniac, right? And look at the things he's saying. He's thinking about himself. He's in love. Come on, people, let's get the patient room, get the drapes up. It's not brain surgery, right? So it's funny because I was doing a case last week and I found myself doing all the same things. And I promised myself I'll never become this person. But it's funny how things change over time. So, it's 7 years. Everyone always asks me this, like, how long is it? What's fellowship, things like that. So once you graduate med school, you do residency, and residency is, whatever field that you ultimately want to do. And our program was 7 years, and we got two residency years. Some programs are 3. Very few programs now are 1 resident, still a year. And the way my residency at Mount Sinai was structured was we did 3 years of junior residency, we did a protected research year, and then we did 3 chief years at different sites in the Mount Sinai system. So, you can see different types of pathologies. We see this kind of a tumor, which is very superficial. It's durally based, right? It looks like it's not involving the brain, it's just displacing the brain away, right? So you can see what this patient has versus what this patient has, which is a much deeper set tumor kind of in the center of the brain. You can see that there's some element of hydrocephalus or swelling of the ventricles with CSF. This is obstructing the outflow of CSF. And you can imagine taking this tumor out is much more complicated than the other tumor, yet they're both called brain tumors, right? So when people say, oh, I may have a brain tumor, what does that mean? It doesn't really mean much. So you really have to go into the nuances of what that entails. So spine, we see a lot of stuff in spine, trauma. This is a patient who had a very severe osteoporotic spine fracture. And you can see there's some retropulsion or posterior displacement of these fragments. There's some pressure on the conus medullaris and the cardia equina, and this patient needed emergency surgery. And then you can see this is a patient here. Let's say these are 2 separate patients. This one's a gunshot wound to the spine. You can see how severe the injury is, right? You can see just pierced right through the T6 vertebral body. And then here, this is something I saw when I was in residency. If someone can maybe comment on this and tell me what they think. What do they think that is? Anyone want to make a guess in the chat box? All right, I'm seeing, let's see.
Yeah, we have gunshot, calcification, brown sequard, bullet impaled through the eye, stabbing, another bullet.
So this is actually a taser dart. So this is a patient who got into an altercation with a police officer, and the police officer had to use I guess, a non-lethal means of restraint, and this ended up in the patient's eye. So you're wondering why neurosurgery was called, and we were asked to clear the patient to be transferred to another center for emergency eye surgery. So it was okay. So from our perspective, there was nothing neurosurgical would do. It was all ophtho. So you can see that we see a lot. We see a lot. It can be very, very interesting at times. This is a patient who had an intracerebral hemorrhage. You can see that there's a blood clot here that we had to evacuate. And then what you ultimately have to do is place a catheter inside the ventricles of the brain to drain the blood and the fluid, because it obstructs the outflow. So this is just me putting that in. This is a bedside procedure. We basically place a tube inside the brain that ends in the ventricular system to drain the blood. So it's definitely demanding. It's rewarding. You can see that this is a picture taken of our class in intern year. Not that many residents, and you can imagine that you have a patient census of about somewhere between 40 and 50 people every day. And you have some of these residents are in the OR, some of them are managing patients on the floor. It can be pretty daunting, but it's good. It's very rewarding. It's a field that if you've clicked to it, and you should definitely get a lot of experience, not only in the clinical aspects, but the research aspects. And if it's something that you feel that you click with and you genuinely can't see yourself doing anything else, which happened to be my case, I say to people, I don't work a day in my life because I love my job. I love what I do. And although it can be stressful, although it can be demanding, right, it doesn't faze me because I really enjoy it. And hopefully you can find that kind of satisfaction in whatever you do. All right, so that ends my little spiel on neurosurgery. Let's talk about what I do, which is complex spine. I'm going to take this little opportunity to answer some questions. So let's see what we got here. Have you ever had your hands injured? No, I have not. I mean, not in any serious way. That's a very good question. You definitely have to be careful, right? Sometimes you may not want to do certain activities or sports at the risk of potentially injuring yourself, because if your hands go, you may not be able to work as a surgeon. Considering that length of residency is a feasible start this path at 40. Yes, I had one of my junior residents was, I think, 38 when he started his neurosurgery residency. So it's definitely feasible. I mean, it's all up to you. What do you feel you can handle, and what you feel your energy levels are, and where you are in life. If married, kids, these are all things that you have to consider. What is protected residency? That means that we had a protected year. We had no on-call responsibilities during my research year, which is my 4th year. How long is the neurosurgery residency program for a physician assistant, and what difference is PS? So the question is, what is the residency for a physician assistant, neurosurgery physician assistant, and what differences do they have rather than the doctors? So in many ways, very similar in terms of the day-to-day activities for the residents and the physician assistants. I'm not exactly sure how long the residency is for them. I think you may want to ask someone who's in that. It's not as long as the neurosurgery residency for an MD or DO, for example. And they work hand in hand with us. Yeah, they're very, very valuable members of our team, and they fit the team perfectly. They're an essential part of our workforce, and in many ways are like the engine to keep us going, because otherwise we'd be chronically understaffed and it'd be impossible to fulfill the duties of day-to-day neurosurgery. How do you train your hands to be stable? That just requires time. That's why the residency is 7 years. Have you ever had to work very closely with orthopedic surgeons? Yes. Part of my responsibility as a spinal neurosurgeon is to also work with spinal orthopedic surgeons, and we work very synergistically and hand in hand. We basically do all the same things with some slight nuances here and there. In general, orthopedic surgeons tend to have a bias on more pediatric scoliosis repair versus neurosurgeons who do more tumors and spinal cord pathologies. That's more our and CSF pathologies. That's more our prevents. What is the pathway for neurosurgery as an IMG student? So the pathway is basically the same as a United States resident. You still you graduate from medical school. You apply to residency as you would normally. And then if you get into a residency program, you just follow that pathway. It can be much more difficult though as an IMG. It often requires multiple research years, and you have to really pick a program that you want to go to and develop relations there and connections. Okay. Let's keep going, and I'll come back to the rest of these. A lot of questions here. So, complex spine surgery. So what is that? So basically, the word complex, or the term complex spine surgery, can encompass anything really. It's not just one or two things. It's many different pathologies, right? So all these things here can be considered complex if you think about it, right? So what do we have here? We have a patient who has been fused from C1 to T12, who developed a fracture and distal junctional failure of their construct, and now has a severe kyphotic deformity. And they also have been fused here at L5S1 via TLIF. You can see that this patient's in tractable pain, right? It's like this and fixed like this, right? So this is pretty complicated, right? All right, now how about this patient? So this is an AP view of a full body X-ray. You can see how the spine has a pretty significant coronal scoliosis, right? With some what we call pelvic obliquity, meaning imbalance in the pelvis and the hips. So what about this patient, and then who has intractable pain and has difficulty walking, right? This is also a pretty complex patient, right? Or how about this patient on the right, who has a previous spinal fusion and is fused in kyphosis and is completely flat. So this was called a flat back deformity, right? And if you remember from medical school, what is the normal curvature of the lumbar spine? Is lordosis, right? So if you have a flat or kyphotic lumbar spine, it's very difficult, and rigidly fused, it's very difficult for the patient to compensate for this, right? How are they going to, they can't do anything about this. So these patients are miserable. They live in chronic pain, and they're often bounced between physical therapy and pain management in this endless cycle that never gets them any better. And they get spinal cord stims and pain pumps and all kinds of things, that none of these things work. And really what they need is, unfortunately, more surgery. So you can see how if spinal surgery is not done right the first time, the patients will continue to need surgery until it's finally done right. So that's why you hear these horror stories, like this guy on the left, he's had like 10 surgeries before. It's crazy, right? Why would you think that the 11th surgery is going to be the one that fixes him, right? But this is the problem, in a way, that it's a never-ending story until they get it right. And what I mean by they, it means you as a spinal neurosurgeon figure out what that problem is. And in many instances, the problem is a spinal deformity. Okay, so that's where I come in. So this is kind of showing the outcomes of each one of these cases. So you see here, this patient, we extended his construct from his T12 down to ilium. We did a couple of posterior column osteotomies to straighten him out, and we placed multiple rods here to stabilize him across this construct. So you can see that this is where he's at now, much more straight, much more harmoniously aligned, and he was doing great, very happy. This patient here with that coronal deformity, we instrumented them from T10 to pelvis. We placed some cement here to stabilize some of these screws, because the patient had pretty severe osteoporosis, and this patient did very well. And over here, this patient with that rigid kyphosis and that lumbar kyphosis and spinal flat back, we did what's called the pedicle subtraction osteotomy, where we basically literally fracture the spine in a controlled fashion or immobilize it. So once you fracture the spine in the middle, you can bend it to where you want, and then you lock it into place with screws and rods. That's how it works. Now, how do we do this? Right? How do we do it? So back in the day, I'm going to show you a video of how we used to do these things. We used to use drills and chisels and hammers, and we used to fracture the spine, blood loss, ICU. Patients were in tons of pain. They'd be in a hospital for weeks, post-surgical drains, high risk of wound infection, things like that, right? And in many ways, we kind of still do it the same way. It's not that much different, but in the past 10 years or so, there has been the introduction of robotic-assisted spinal surgery. Okay, this is very different. When people think robot and surgery, they think Da Vinci, right? This is not the Da Vinci. It's very different. We have the Da Vinci has not really taken a foothold in neurosurgery yet. What this is basically a robot that helps us place instrumentation. Okay, so what happens here is you put in the coordinates for the robot, right? You say, that, and that arm, you see this arm over here, will move to where you want it to go, right? And then you, as a surgeon, use the correct instruments, a drill, a tap, and then put in a screw at each level segmentally. So you go like L1, L2, L3, L4, L5, S1, ilium, and this robot will bring each one of those spots. Okay, and it has, and then there have been multiple studies to show that it's very precise, very accurate. Now, is it very different from using spinal navigation? And what is spinal navigation is, if you've been in a spine surgery OR before, it's basically we have a computer screen and we have a little pointer that we point to a spot in the spine, and we look at the computer screen and it shows us exactly where we are in the spine. Is it very different from that? Not really. It's basically some variant of that. Okay. Now, how did we do spine surgery in the past? In the Stone Ages. Okay, so let me just give you a little setup here. This is me, actually. This is I graduated from fellowship at the Cleveland Clinic, and I stayed on a year there as an attending. So this is me at the Cleveland Clinic, operating. It's me right there. Kind of, you can see a little bent over. This is my assistant. This is an orthopedic surgery resident, and then this is my scrub. This is my surgical tech. So he's passing me the instruments. Okay, so just give you a little background here. So you can see what I'm doing here is I'm about to place some screws into the spine for a patient who had a spondylolisthesis or a slip disc. So I just want to point out a couple of things. So you can see there's a lot of passing back and forth of instruments, right? I'm using what's called Lexel rongeur before I use the chisel. And you can see there's a lot of, a lot of movements on the part. So imagine ergonomically, this is difficult. Imagine if you do this on every single level, right? This is going from, let's say, T12 to ilium. You're talking about over 7 levels. I mean, it's very, very difficult. I'll fast forward a little bit. So you can see then we're taking a probe, we're introducing it into the pedicle, and through the pedicle into the vertebral body. Okay. You see, he's providing some comic relief over here in this video. Okay. Getting the instruments, and he was very attuned to the way I like to do things, so I didn't have to even tell him what I wanted. You see, I'm not even looking at him, he just passes it right to me. He was a great scrub tech. So there you go. See, a lot of twisting. What we're doing, we're basically creating a channel through the pedicle into the vertebral body. Okay, now that instrument there is feeling it, so you feel it, make sure there's no breaches, you're not in the spinal canal, you're not somewhere lateral. Then I put the screw in. So this is all done by me, right? So this is all done. And now imagine that's just one level. Now I got to do at one side, right? So I got to do, let's say that's L3. So I got to do L3, L4, L5, S1. And then I got to go on the opposite side, L3, L4, L5, S1. And just literally repeat this exact same step over and over and over again for each level you want to do. All right. So look at the difference between that and here, the robot. Okay. The robotic arm brings you to where you want to go immediately. You place in it. This tube guides you where you want to go. You use power instruments, not manual instruments, right? So that's basically the drill. It creates a channel. And also try to watch here and watch the screen, okay? Because I want to actually let me go back because it's important. So the robot arm brings you to where you want to go. You place in the tube, right? Now you have a navigated drill. Look at the screen, right? See, it tells you exactly where you're going to go. See, you drill, tells you your depth, right? And that screw there is telling you what your screw is going to look like when you're done. Okay? Take the tube out. And then you can see when you're putting the screw, right? These are all power instruments. So it's so much ergonomically better for the surgeon, right? Rather than that manual drill. Better for your wrist, better for your hands, better for your neck, everything, right? There you go, done, finished, right? So you see that, you can see with the benefit of this. It's very clear as when I put these things side by side, you can see the benefit of this. It's a good system. Now it's not perfect, and there are many reasons why it's not perfect, but it's a good system. Okay. So what's nice about this? So robotic guided spine surgery, it's kind of a marriage between the hardware and the software. That's the beauty of it. You get the software component of it, which tells you all this stuff, and this is continuously advancing, and the hardware component of it, which is placing your screws and rods. Okay. Now, what's nice about it is that the real benefit of this is placing pedicle screws. And what pedicle screws are basically titanium screws that we place into the spine, the bone of the spine that traverses the pedicle. And what is a pedicle? A pedicle is a piece of bone, a wedge of bone that connects the posterior elements to the vertebral body. That's a pedicle. Okay. What this does is spans all 3 columns of the spine: the posterior element, the middle element, and the anterior element. Okay. That's the beauty of the pedicle screw. Back in the day, most of the spinal instrumentation was only posterior fixation. We used hooks and wires and rods and things like that. And we only fixated the posterior aspect of the spine, not the anterior middle columns. So things would not really turn out the way we wanted them because we didn't traverse all three columns. And that was the beauty of the pedicle screw. Okay. So again, what's nice about the planning software for robotics, you can see every level you can plan exactly the size, the length, diameter of your screws, right? So it's not a guessing game. It's all done, right? It's not like I'm filling it out. Oh, I need a 45 millimeter screw, 6.5 millimeter diameter, put them in. It's very different. It's a very pleasant operating experience. Everything's planned in advance. You know exactly what you're going to do, what your plan is, what you're going to get. So it's been it's very beneficial. Now, where the real benefit of this shines, right? I showed you an open case where I was doing before, but really for minimally invasive surgery, this is where the real benefit is. The robot. So you can see that here is you can see that we can accomplish many of the same goals as open surgery via a much smaller incision. Okay, and you see that there's a difference in the screws. This is the pedicle screw, and this is the inset where we can kind of place the rod. Okay, back in the day, the way we used to do this, excuse me. The way we used to do this was we used to do this with fluoroscopy, which is basically, if you've seen this, literally a C-arm that comes in the room. And what this does,
Delayed, bless you.
and what this does is it gets X-ray images, intraoperative live X-ray images of the spine. So you use AP and lateral views to place your instrumentation. And you can see on the left-hand side, this is like the perfect example, right? If the patient's obese, or you have an old machine, or you have a tech that doesn't really know what they're doing, it can be, look at this. This is like my case the other day. You can see how washed out these images are. And you can't see anything. It's very difficult, right? And this is the reality on the right. This is the best case scenario on the left. So reality is very, very different. So like, how do you place screws here, and in a way that you're confident? It's very difficult, right? So what's nice about the robot and the imaging software that captures these images is that it can compensate for all of this washout. It can give you an image that's very fixable and readable, right? So what it does, it has the AI in these systems is so advanced now that it kind of knows exactly what it wants to do. It tells you exactly where things should be. So it's very nice. And in particular for patients who can be very obese with a very large body habitus, and if you're doing these big open incisions on these patients, they can be very prone to wound complications, as is the case in this patient, who ultimately needed many washouts, debridements, wound vac. It was kind of a disaster. Now, what's nice about minimally invasive and robotic spine surgery is that you can actually have almost a designer type incision, right? So this patient had a tattoo that she was very, very keen on keeping intact, right? So if we're doing an open incision, the incision would be something like this, right? Right down the middle, right? So I'll go right through her tattoo. But here, we were able to kind of compensate and work around this tattoo, see that? And which I think at the end, she was actually very pleased with this, but we got a pretty nice cosmetic result there. So it looked pretty good. She was very happy. Now, sorry, I have this laser. Okay, there we go. So with now with larger constructs, right? So this is a patient who had a previous fusion from T10 to ilium, and they only put one iliac screw, and the patient developed a pseudoarthrosis at the bottom, right? Now to revise this is very difficult and it can be quite challenging. What's nice about using a robot is that we knew the problem was down here, okay? So what we were able to do was basically work around with the previous hardware. We didn't have to remove anything, and just basically re-instrument it and get a couple more points of fixation in order to get this patient back to the spinal alignment that they needed, okay? So what ultimately we did, you can see that we planned everything out. We're placing 2 iliac screws. This is very difficult to do with navigation. With the robot, it becomes very, very simple. We were able to place, you can see how we did bilateral iliac screws here. We were able to link it up to the previous construct, and we extended up the construct a couple more levels just to get a little bit better fixation. Now, let me just use this opportunity to answer some questions here. Okay. Okay. Why are titanium screws used? Are there no alternative metals? There are alternative metals. The reason titanium screws are used is that they're MRI compatible. They have minimal they don't have as much metallic artifacts as other things such as stainless steel or cobalt chrome. They are reliable. They are strong. The modulus of elasticity is in many ways similar to that. Uh, it's a little bit stiffer than bone, but now they're coming up with variants that are very similar to bone, right? Because if your other alternative is PEEK, which is a type of plastic basically, and that modulus of elasticity of that is equal to bone. However, it's been shown to have high rates of pseudoarthrosis. So titanium is strong, it incorporates the bone well. Bone likes metal, that's the thing, rather than plastic. So that's why orthopedics, they use a lot of metal, metallic implants. Does this technique decrease time it takes to operate? It often adds time. It often adds time. But once you have, and usually that is just setup. Once the staff is accustomed and comfortable with setup, then it usually becomes similar. It never quite gets faster, but it becomes similar. Maybe adds 30 minutes to your case, 30, 40 minutes. It's not too bad. What is the future of robotics in neurosurgery? I'll get to that. Do they still teach residents? Okay. Do they still teach residents the old technique, or what it was called freehand? That was the name, the freehand technique. Is this technique used all around USA, considering the equipment is expensive? All right. So the bottom line is, yes, we still teach freehand technique. You basically have to be very comfortable with freehand technique before I would ever do any sort of image-guided robotic spinal surgery, because it's not perfect. In many instances, it doesn't work, or it's inaccurate, or it's not giving you the results that you want. So if that's the case, you have to convert to freehand, right? So you have to be comfortable with that. And that's why I say, like, if you can't do this case freehand, you shouldn't be doing it, so it's very important. It's very, very, very important. And you bring up a good point that over time, as people are adopting these technologies more and using them more often, the freehand technique is becoming a little bit more archaic and a little bit I'm starting to see residents who've never done freehand screws. So it's something that we as a field need to address. How common is thermal necrosis? How is it combated? It's very rare. Are patient outcomes improved using robotic assisted surgery? Any downsides? I'll talk about that in just a little bit. Okay, so let's keep moving. How are we doing with time? Okay, we're doing good. So now with this, you also have other techniques such as a kickstand rod. Just a little bit advanced. I don't want to get too much into this, but basically what this is a way of correcting a coronal deformity in the lumbar spine. You can do this technique called a kickstand rod. This is it. This is your kickstand rod right here. Okay, this thing. What this does is it basically pushes the pelvis down so you can correct a coronal deformity. See how the deformity curves like this, right? So what you're doing is you're basically pushing this side down so that everything kind of balances out. Okay, there's a little bit of imbalance in the hips. See that? So okay, so that's basically how that works. Now, another benefit is for patients who are medically challenging, right? This is a patient who had very severe osteoporosis, progressive deformity, restricted lung disease, all kinds of issues, right? So what did we do? And this patient kind of was young and needed surgery. So what do we do? An open surgery with a big incision would be very difficult, and this patient would be very prone to having lots of issues. So what we're able to do is use a robot and place these screws in a minimally invasive and stereotactic fashion. And it really shows the benefits of using a spinal, using deformity surgery in order to the benefits of robotic surgery in deformity surgery, because the quality of your fixation is critical and is often challenging. Okay, now this patient also happened to was so pleased with the results of the surgery that she actually ended up getting a tattoo along the sides of the incision. So it was kind of interesting. So another thing that's very nice about robotics is the placement of screws in the setting of pediatric scoliosis. So here we have a patient who has a pretty significant idiopathic adolescent scoliosis with a severe thoracic coronal deformity. And you can see they have shoulder obliquity, right? Shoulder imbalance, they have pelvic obliquity, all those kinds of things. And this is just showing you a picture of what they look like See the rib prominence right here, right? So what they look like when they're standing up and when they're bending forward, right? So this patient needs surgery. Now, sometimes it can be challenging to know, like, where do you go, where do you end, and where do you start, and where do you end in terms of your construct, right? Do you start here and end here? Do you start here and end here? You start here and end here. You know, it's very difficult to know, and that comes with you know 5 to 7 years of residency, fellowship, years of training and practice, mentorship, right? So that's the thing that you don't see. That's the fact that to know to do this. This is the reason why the training is so long and it's so difficult, because there are not that many people who can do this. There are not that many pediatric scoliosis surgeons in the country or in the world, for that matter, right? So it's the training has to be rigorous and difficult, because the pathology is rigorous and difficult, right? So anyway, so when you instrument, right? When you instrument, it's difficult to predict where you're going to get at your end result, right? So here you can see that this was where we started with. This is what we ended with. How do we know? So what we used was the planning software of the robot to input the patient's preoperative x-rays. And the robot basically said, you should do this, right? And we said, why? Well, if you do it this way, right, you can see how things get better, right? Look at this is where we start off with, okay? So this is what you're going to end up with, right? So pretty good, right? That in and of itself is an excellent, excellent, excellent way to demonstrate the power and the capability of the robot. And this, by the way, this was a case I did about 3 years ago, okay? It's gotten significantly better since then. And that's the thing, the technology and software is improving constantly. It's getting better. Now where the software is heading is for the robot to collect real-time intraoperative data. So it's not only just a machine that kind of giving you what to do, advice, but it's also like collecting data, so that the next time you do the case, it learns and it gets smarter at doing its task. And that's kind of where these things are heading, which is great. So you see, this is where we got this result, which was a really nice result. Okay, let's see what's going on here. Let's do some questions. What do we have here? What do you do if the patient's allergic to metals? It's very rare for someone to have a titanium allergy. It's very rare. There are ways to work around it. So you just use PEEK. There are ways to work around that. It's very rare for a patient to have a metal allergy. I've only seen it once in my entire residency, fellowship, attendingship. And then what you do is you basically remove the screws and use a different type of hardware. They'll develop a pretty robust pseudoarthrosis. Can robots be used in revision cases? Yes, actually, most of the cases I showed were revision cases. Are there any inoperable scoliosis cases, or are there any cases where surgery would not work at all? I wouldn't say there's any. I mean, inoperable would mean it would imply that the patient cannot survive surgery. Okay. Are there cases that are truly inoperable because of the severity of the scoliosis? No, right? But are there cases that surgery is not a good idea? Yes, definitely. Where the morbidity of this is so high that it doesn't make sense, Is more research needed to support the use of, this is a good question. Is more research needed to support the use of robotics in neurosurgery, is well established already? It's been around for a little over 10 years. It's very well established. The main papers that have come out have basically compared robotic spinal surgery to traditional fluoroscopic X-ray pedicle screw placement, which is it's not really a good comparison. When they compare it against navigation, it doesn't really hold up as well. But there's still more nuances, or there's still more research needs to be done, as with anything. But it's pretty well established. It's not like you're doing anything that's experimental at this point. It's very, very well established. Okay. All right, very good. Let me just take a look at the chat box here, because it looks like people are posting in both.
Yeah, just for clarity for Dr. Rasouli, if you could put your questions in the Q&A, that would be greatly appreciated. Also, we can record your questions in the Q&A and answer them at a later time on the chat. We can't always record the chat, so put your questions in that Q&A box, please.
Thanks, Anna. Do you collaborate with computer scientists and engineers with utilizing technology and robotic tools in this field? Absolutely. This is by Polly. Absolutely. That's one of the reasons I loved neurosurgery, is because our field is constantly adapting with technology, right? So the engineers, they're not in the OR, they're not operating, so they don't have that hands-on insight that the neurosurgeons have. So they always come to us and are asking us for advice and questions, and hey, how can we make this better? And I love collaborating with them on that, because it's great, because you always need that surgeon input. What comorbidities would be contraindications for revision surgery? The main comorbidities are basically any sort of main comorbidity for any surgery, really. The main ones are really like BMI. The main ones I look for: BMI, smoking, out of control diabetes, osteoporosis, and a patient who is on very high doses of preoperative opioids before surgery. Those patients, they need to be optimized before they get surgery. You can't just sign them up and get them. They will guarantee they're going to have a problem. They're not going to do well. You really have, in particular, the main ones I say are obesity, smoking, and high opioid use. Those three are just disasters if they're not fixed. You're not going to get a good outcome no matter what. You can do a perfect surgery, that you're not going to get a good outcome. You ever operate on Bertolotti syndrome patients? How are the outcomes when you resect versus fusing lateral Bertolotti syndrome patients? So Bertolotti is that's a little bit outside of this talk. What that is basically a type of it's a type of sacro a lumbosacral I don't want to say malformation, but it's like a lumbosacral variant, anatomical variant of your where the transverse process of your L5 vertebra touches or fuses with the sacrum on one side, and it forms it can form a joint. It can be on both sides, be on one side, it can be partially fused, totally fused. So the answer to your question, Renee, is yes, I do operate on those patients on a very select basis, and in general, they, you know, you can email me if you want to know more about that. Given the rapid operative improvement of bone structure, would there be significant backlash on the deeper dorsal muscles? Good question. Why there can be, and there's often these patients need physical therapy. They need to, you know, they're not like, they need a little bit of time to recover from the surgery. It can take a couple of months, and you have to get used to their new selves, right? Remember, a scoliosis like this didn't happen overnight. It took years and years and years, decades in some instances, to get to this level. And in one surgery, in one 3 or 4 hour surgery, you fixed everything. So the brain and the spine and the arms and the legs and the body all have to get used to your new you, as I say. So what I always tell my patients is, when I do a surgery, like deformity surgery like this, it's like buying a new car, right? The first 1,000 miles is the break-in period. You got to kind of, you have some oohs, you're gonna have some ahs, you have some pain. It's all normal. It's all part of the break-in period. And then usually the break-in period is over around 3 to 6 months. That's when they get the maximal benefit from the surgery. All right, man. Oh my goodness. I'm getting a lot of questions here, which is good. I like that. I like you guys are engaged. It's very nice. How does the robot collect data during a surgery? So the way that happens is that you have to input variables. So like the length of time, EBL, you know, how long it took to put in certain screws at a certain level. It'll collect all this data as you're doing that. So then it just compiles it and runs analysis on it. So it'll tell you like, oh, theoretically, for example, you know, it takes you longer to put an L4 screw consistently. So maybe you want to start with that, or maybe you want to skip L4. Who knows? Something like that. Any preventative measures one can take regarding scoliosis? Not too much, because most scoliosis are idiopathic in nature, and some combination of genetics and epigenetic factors. There's not really a way to prevent it, but it's really the best way is early screening. And if it's caught early before it progresses too far, there's certain interventions such as bracing, physical therapy, things like that, that can certainly slow, and in some cases, in rare cases, maybe prevented, but really it's more about slowing it and stabilizing a curve. What is the recovery period between open versus robotics, open surgery versus robotics? In general, the recovery period is less for robotics just because the incision is less and there's less muscle dissection and tissue handling. So the patients don't have as much pain. Open is a lot more, so they usually have more pain. They usually require more time. Do you need a background in engineering to be in this field? No, you definitely do not. Actually, I have a background in engineering. My undergraduate major was biomedical engineering. So I happened to have a background in engineering when I entered medical school and entered neurosurgery. Maybe that's why I got interested in neurosurgery, because I always liked the technology. I've always been kind of a nerd in that way. But you don't need a background. I don't know many neurosurgeons at all have a background in engineering. Does every residency program teach robotic techniques? No, not every residency program does, but every residency program should teach you fluoroscopy, navigation, and freehand technique. Robotic is kind of like the cream on top. That's like it's almost like having a Lamborghini in a way. But you can still, it's like having a Lamborghini to go to work, but you can still get to work with a Toyota. You can still get to work with a Tesla. The different ways of doing the same thing. All right. So what are the benefits of MIS? I want to preface by saying I'm not really. MIS is good in certain patients, right? And it has clear benefits, but not every patient is a good candidate for MIS. And in my practice, I do most of my cases open. I don't do too much MIS surgery because so it's not always MIS the best way to go. Okay. But it is a very good technique. And all the benefits are very, very well supported at this point. There's less postoperative pain, fewer wound complications, much faster recovery, right? Less risk of blood transfusion, length of stay, fewer medical and surgical complications. I mean, the benefits are really there, but also the downsides of MIS surgery is not like always a good thing, right? Because if something is so radically better, then everyone will adopt it, but it's still not completely adopted yet. So this is just showing you some more examples of like somebody who we did a MIS surgery for degenerative. They had degenerative scoliosis, right, and had a big disc herniation right here. You can see it right here. Nowadays, the way I would do this is I wouldn't even use. You can use a robot to bring a tube. What we did is, we decompressed, we took all that stuff out, but you can use this to kind of help you. Now, if we were going to do this kind of the old school way, right? You can see a big incision down the middle, right? Right here, big incision down the middle. The way you can do it with a robot, small incisions here, same surgery, right? So you can see the obvious benefits of MIS and robotics versus the traditional open. Now, that being said, at 1 year, no difference in outcomes. Both patients are doing well. They're very happy. One has a little bigger incision, the one has 2 small incisions. They're both cosmetically happy because you know why? Patients don't see the incision on their back, so they don't really care, from my experience. And they don't really mind it. So I don't really tell them, or in my opinion, a smaller incision is not necessarily a benefit of MIS. It's really the tissue handling. That's the benefit, right? Yes, a little bit better cosmetic result, but it's certainly it's not something that patients generally care about. They're more concerned about getting out of pain and being able to walk. That's the main thing. Okay. Now, you can use for other uses too, not just pedicle screws. So this was an example of one of my partners who did a facet decortication. We used this acetabular reamer to basically get inside a facet to decorticate that. You can use this for MIS decompressions. You can see that we use tubes here. We drop these down to get down to the disc space and take that out. Nowadays, I don't do this. I use endoscopy, which is maybe definitely a subject for another talk. What we do there is basically we use endoscopes to get down to the disc space and we take the disc out. This is showing the same thing in different view. Just more of the same thing. All right, now I got a lot of questions on the downsides of what are the downsides of robotics, right? I didn't really talk too much about that. All right, mainly it's here. Look at the OR, right? Complicated, lots of equipment, lots of setup, lots of trays, can take a lot of time. Okay, now that's the problem. It adds up. There are 2 things bad about robotics. I say cost. It's expensive to get the equipment, and then it's expensive to maintain it, and then also the time. It undoubtedly adds time to the case. But the thing is that with the robot, right? If this gives you the confidence and the ability to do your surgery safer and better, then you should use it. Okay. But if it's something that doesn't really add much, then there's no point in using it. If you're good with nav and you have a good setup and your team is good, then there's no benefit to the robot really. But if you're able to, if it really benefits your workflow and you have a good team and stuff, then it's great. Yeah. So you can see what I love about it is just like how awesome the technology is and how that's so applicable uniquely to spine surgery and how it's really transforming our futures here. And what we're really trying to do is they're trying to like get every aspect of the spinal OR in some way, shape, or form connected. That's the word, that's the buzzword they're using now, is connected. That they're collecting data about everything, the implants, levels, this, that. So it's great. And this really adds up. And when you get all this data, you can really make some very informed decisions on how you're going to like do things clinically. So where things are headed, like there are certain things in terms of like the instruments that they're going to navigate, so you know where you are. They're going to try to develop robots that can do decompressions on their own. So you just plug in some numbers, and then like it'll do the work for you, which is good. Like right now you have to do the decompression on your own. The robot only pretty much puts screws or navigates you to a certain area. So this is a paper I've developed looking at artificial intelligence robotics and spinal surgery. It's a meta-analysis. If you guys want to look at it, I published it in 2020. So there's obviously some more papers since then, but it was a pretty comprehensive review. So what do we find? We found that the overall accuracy is about 95-98%. So as we look at all the papers that are published, so far it's been done over 1,000 patients. At this point, even way more than that. These are all retrospective studies. However, these are all retrospective. There was some conflicts of interest, right? And whenever you have those two things in play, there's always a possibility of therapeutic illusion and confirmation bias, right? So always take things with a grain of salt when you have retrospective studies with conflict of interest, right? These are two things that can always be in play, right? And that can be certainly here, okay? Now we were able to use robotics for a case that we did in Staten Island. It's just illustrating this, and then I'll wrap it up and then we can have some questions. So this is a patient who had very severe stenosis, or what's called adjacent segment disease above a previous construct. They've been fused from L4 to S1, developed adjacent segment disease at L3-5, L3-4. You see there's loss of disc space height. There's posterior disc osteophyte here causing neuroforaminal stenosis and some central canal stenosis. So we did, and in this patient, it's a little bit hard to see, it looks a little weird, but this patient has peak interbodies, see they're kind of see-through, and peak rods, which we don't even use anymore. So it's very kind of what I call an old school construct. So what we did is we positioned the patient. We did a what's called a OLIF, or an oblique lateral interbody fusion, where we go from the patient's side and trunk rather from the back. So the trajectory is basically like kind of almost like from the front, right? So the patient's in a lateral position. So we registered the instruments, we got everything set up. You can see where our incision is. It's not the patient's back, by the way. The patient's lying in the left lateral decubitus position, FYI. Okay, so you can see how things are infiltrated, right? You can see that the software tells you exactly where your trajectory will be, right? So we localize the disc space, this is L3-4 disc space, right? This is kind of bisecting it. You want to say coaxial to it. This is the posterior aspect of it, right? There, right? This is not so great, but this is the anterior aspect of it, right? And your trajectory is going to be like this. This is your trajectory, right? This is your iliopsoas, this is your iliopsoas, this is your vena cava, this is your aorta. Okay, so look at it. You can almost see it, right? Look at this is the X-ray. So this is before and this is after. I'm kind of tracing it out. So you can see there's a nice corridor to the vertebral body. So a traditional lateral approach is this blue line right here. See, it's a traditional lateral. You go through the psoas to get access to the disc space. This is more of an anterior to the psoas approach. So this is just kind of us using some of the instruments to get down to the disc space. We navigate it down, place our shavers, our implants. This was showing what the implant would look like, right? And then that's the final product. So you can see that we were able to get some nice restored disc space height. We restored spinal alignment. Patient did great. They went home the same day. So you can see that the benefit of the lateral or the oblique approach is that the patients have less pain, and they are certainly able to go home post-op day 0 from a spinal fusion. It's one of the only ones where you can really do this. Okay, so yeah, so that's a lot. I threw a lot at you guys. So let's see. what do we have? All right, so if I can,
And we have about, we just have about 5 minutes left. So Dr. Rasouli, you're welcome to finish your presentation or finish with questions, whichever you prefer.
Great. I'm going to do one thing here. Let's go back. I'm going to ask you guys to, if you like my presentation and you want to follow me on Instagram, these are my social media handles. Just follow me. I'm a shameless plug for me.
No, we love socials. We love it. So, and I'm going to share a social slide with all of our Lenox Hill socials later, but you guys take a screenshot, follow Dr. Rasouli on Instagram. His page is amazing. Is it okay if I share your email with the chat, Dr. Rasouli?
Yeah, absolutely.
All right, I'm going to post that in the chat right now. Make sure you don't forget to screenshot it or copy it.
So, yeah, I'll answer like one or two more questions here. Let's see. Yeah, a lot of these questions are very complicated questions.
I told you they love spine.
Yeah. Okay. Yeah. You know what? Actually, you know what? I'm gonna stop right here. I'm gonna ask. So I think I might be hosting next week as well too. Next Tuesday. Okay.
That's correct.
How about you guys post in the chat room? What would you like me to talk about next week? That may be a better question that I have for you guys. What do you guys want? I was thinking I could talk more about other techniques and stuff like that, or I can give a talk about, like last time I gave a talk about neurosurgery, talked about myself, talked about how I got interested in neurosurgery, you know, some of the different, how to like get into neurosurgery, kind of like my little private.
Just know this Sabatini lady, if I call her by myself.
Yeah, I'll call.
So it looks like more robotic surgery, single case study, tell your story.
Yeah. Okay. Yeah. Cool. I'll do that. I like that talk too. So let's do that. We'll do some combination of both. I'll talk a little about my journey, my path to neurosurgery, and then I'll talk a little bit about some of the cases that I like. And so we'll kind of keep it a little bit of both. Okay. All right. So I guess that wraps it up. Thank you so much for having me. This is great. A great experience.
No, thank you again, Dr. Rasouli. We really appreciate you making time for the webinar during your busy schedule, and we're really excited to have you back next Tuesday for another virtual OR. We're getting lots of thank yous. Again, if you guys have questions for him, his email is in the chat. Be sure to follow him on socials. We love to get social here at Northwell Health, and we believe it's the new way to stay connected with patients and with students. So don't be afraid to follow us. I'm gonna end this meeting so that we can have a clean recording. Dr. Ben Shalom, I'll start the meeting again so you can join, but we'll see you guys in 1 minute.